Okay, good morning, the people in the US, and good afternoon, good evening, the people in East Africa, mostly Kenya. Today we're going to have a medical-based topic. We are talking about the eyes and the oral care in terms of what what we need to know and what if and how oral and eye care is a reflection of your body's health. Our presenters are Dr. Hao, who's a dentist in Nairobi, and the other presenter is Dr. Lois, who's an ophthalmologist in Nairobi. So we will start off with Lois. She has a short presentation, and then we will straddle between Hawa and Lois. So welcome. Lois, go ahead.
Okay, thank you so much, Dr. Aswani. Good morning and good evening to everyone from wherever you're joining us as is relevant to you. So my name is Dr. Lois Mwangi. I'm an ophthalmologist, and my interest is really about people knowing about their eye health and knowing when and how to seek help for your eyes. So I've titled it The Eye and You, basically trying to shine light or shed light on you getting to know how your eye functions and what parts of your eye could be affected when your vision is blurry or affected. So when we look at the first picture, this is what we appreciate in people when we look at each other or when we look at ourselves in the mirror. This is what we see, which basically is 1 part of 6 times what your eye is. So the real picture of your eye is this second picture, where you have the different parts of the eye, starting anteriorly or from the front going backwards. So from the front, you have the window to the eye, which is usually a clear membrane, which is the cornea. And you have what we call the anterior chamber of the eye, usually contains a bit of fluid inside there. And you have what we call the angle of the eye, which is where this part, the clear part, meets the colored part of your eye. So the colored part of your eye in a cross section looks something like this, with a hollow aperture in between, which we call the pupil. So the colored part of your eye is this whole part, which we're seeing in cross section as this part and this part, and we name it the iris, okay? And right through the hollow part, which we call the pupil, you can be able to appreciate the lens of the eye. So this is the structure that moves forward and backward and changes in size and shape to be able to help you do something we call accommodate, to be able to visualize an object more clearly and more sharper. You make your image sharper. Okay, it's suspended here by something we call the zonules. Okay, and then you have a jelly that's more or less very clear without blood vessels, called the vitreous. Usually gives the eyeball the shape, and it also acts as a refractive medium for the light that is passing through this aperture and through the lens all the way to be refracted all the way so that it can reflect here on this yellow part of the diagram, which we call the retina. The retina basically works like the camera film. If some of you would remember what cameras used to be like before the digital cameras and the phone cameras came about. So you used to put in a film inside that would trap the images, and then those images would therefore be processed in some lab and you'd get the image as a photo. So the retina pretty much works like that. It's got numerous blood vessels, and it's got the nerve fiber layer. So the nerve tissue and the blood vessels that are coming in would be then collectively collected into the nerve that connects to the brain. Yeah, so basically that's the basic anatomy of your eye. That's very important to understand when we want to understand the ocular structures and how that would then affect eye health when we have systemic illnesses. Dr. Aswani, do you have any questions that far that would?
I think also the other reference we can use instead of picture films is X-ray, MRIs, or CT scan films. I think those ones, at least this Gen Zers would know. No, I think that the anatomy is clear. So so what should we do as in why should we have our eyes checked, and who should check our eyes? Should I go to Optica? Should I come to you? What should I do?
That's a good question. So Optica would be a good place to start, or any optical shop would be a good place to start. Our current drive, at least in the Kenyan market, is to have the people who work in optical shops to be as well versed with other eye health conditions that someone would present with, other than just the need of glasses. So who needs to see the eye doctor? Basically, we recommend the ophthalmologist, because that one is trained to both be able to pick up if you need glasses and if you have any other disease that would need urgent attention other than just requiring glasses. So basically, everyone should get an eye checkup at least once a year. Okay, that's for everybody, whether you're 2 years old or you're 82 years old or 102 and beyond. So basically, get your vision checked.
Sorry, and do my people in Eshibinga have an ophthalmologist, or who do they see?
So the current situation in the country is at least in every county referral hospital, there's either an ophthalmologist or a clinical officer trained in cataract surgery. And what the clinical officer who's trained in clinical surgery goes through during their training involves a bit of being able to pick up the eye pathologies, which if he's not able to handle, then he would know where to send that person for now the attention by the ophthalmologist. So the county referral hospitals would be a good place to start.
Okay. And so in terms of care, like what am I supposed to do to take care of my eyes? Like, for instance, my eyes have a, for lack of a better word, a cathingy. I know what it's called in medicine. It's called a penguequila, that thing, or a pterygium. And I know it was from sun exposure. But what is the general eye care that you would advise someone in Muthaiga and someone in Isulu, in Kakamega? All villages in my shags will be mentioned.
Okay, so we start off with assuming everybody has good eyesight, and so they're seeing well, they are okay. So those ones, other than having their eyes at least checked once a year, the main thing would be proper diet, active lifestyle, you stop smoking, and most importantly, in this part of the world, if you're in Kenya, you should always have a good set of sunglasses. Because like you mentioned, Dr. Aswani, you pretty much have good eyesight, but you have what you're calling a cathing that's been growing, and it's because of sun exposure. The thing is, for a very long time in Kenya, it was looked at as maringo, quote unquote, put on sunglasses. But you realize that we are exposed to so much sun in this part of the world. So if you don't wear UV blocking sunglasses, you're most definitely going to end up with some of these repercussions of too much sun exposure. And one of them is now that pingueculum, which is a growth that is as a result of the tissue in your eye getting overexposed to sunlight. The other thing is the lens. As we grow older, the lens of the eye becomes more and more opaque, and that's what leads to development of cataract. The more UV exposure you have, the sooner you will get the cataract. So you will find in these parts of the world, the age of onset of blindness causing cataract is much lower compared to people who are more used to blocking the UV using sunglasses. So those are very basic but simple measures in which you can apply on day-to-day basis that would give you better eye health.
And what about school screening here? I know, like, my daughter's eyesight was caught during a routine eye check at school. As in, it's not even something fancy. It's just that what we call a Snellen's chart. That chart that has a big A, and that's how because she kept complaining. One eye of hers was not seeing, and as a Kenyan, of course, I was like, you're just you don't want to go to school. So, is routine school screening, Kizungu, is it a thing? Like, do ophthalmologists, opticians, and the clinical officers, are they doing routine? And it's not even done by medical personnel. It's just me as a stay-at-home mom with a chart. I just go put it there and I'm like pointing. It's a very simple thing, but it has like my child wears glasses because of that.
Wow. Okay. Currently, we don't have an established school screening program, which is something that I feel should be part of, before children join school, they should at least get and I put it in the slide that this is a personal opinion. I highly recommend to have a vision assessment before starting preschool, because a lot could be averted or caught at that point for those pediatric patients or children. So currently we don't have that. However, I have a colleague of mine who's working in Kitale, and he's rolling out a program called PEEK, PEEK, where children can get assessed, their vision can get assessed using something as simple as a smartphone, which is an everyday gadget nowadays in Kenyan households. So how he's rolling it out is that teachers use the PEEK program to get the children reading using the PEEK, and that way any child with vision disability would be picked up by the class teacher. And I think there's a way that PEEK program sends a message to the parent, and the parent is also alerted to take the child to see the ophthalmologist. So it's a whole program that's currently being rolled out, starting in Kitale, and hopefully to roll out to the rest of the country. But meanwhile, before that catches up to the rest of the country, my recommendation is that to anyone who's watching and to anyone who would hear this, pass it around. Just have your child assessed by an ophthalmologist just before joining preschool or at the age of preschool, because then there's vision appropriate charts that we can use, even if they don't yet know how to read the A that Dr. Aswani is talking about, or the X, or whatever letter is on top of the chart. Yeah, there's different charts that we can use for age appropriate to be able to pick up a vision disability in a child. And we don't have to wait until the child is complaining. We can have that child checked before they even have a complaint about it. And allow me, Dr. Aswani, to then mention the other category of children that we should check is any child who has a squint. Basically, if the eyes are not aligned. Yeah, we call it in Kiswahili in a very bad way, macho chongo. So if a child, or makengeza. If a child has a makengeza kind of look, that child should be examined. This one, don't take to Optica, just take to the ophthalmologist. Okay, and if the child is said to have a white reflex at the pupil, okay, so some of the people will say that anaonekana na macho ya paka, like cat eyes, at night mostly. Because what happens at night is that in the dim illumination, the pupils will dilate. So the pupils will look a little bit larger. So those children, if they have a white reflex, it will show more at night than during the day. And those are children that should get urgent checkup by the ophthalmologist. And I said a good place to start would be a county referral hospital.
Okay. Let's shift to the teeth side. So Howard, do you have a tooth structure, or should I look for one?
I have a model.
Okay. Oh my gosh. How are you extra? Let's stop sharing so that one how.
Yes, stop sharing.
Okay.
Yeah. So just use this for demonstration, right? So the assumption is that all of us have a mouth covered all around with muscles, and there's skin, there are lips somewhere in front here, there are cheeks on the side. So what I have here shows the teeth, it shows the tongue over here, and it shows the gums. So for the structure and in terms of how this mouth shows us what is going on in the rest of the body, this is what we use. So as an introduction, I would prefer if all of us were to use a mirror or use our own mouth to gauge whether we have issues or whether we don't have issues. Yeah, so that would be my introduction, Daktari.
So in terms the same could you just do like a TLDR or the structure of the tooth, like what are the parts of the, and you can just point on that model, like what do we see and what don't we see that is part of the tooth, or part of, okay, what are dentists in charge of?
The parts of the teeth. You say the parts of the teeth.
Yeah, meno. Part
Meno.
Part of meno.
Okay, so our teeth they come in, what we see is the whites. Yeah, so maybe I can draw, I don't know.
Okay, let me look for a structure.
The tooth looks like that. There's the outer part, which is the enamel. Then there's an inner part, which is the dentine. And then there's a space here, which has blood vessels and nerves. So that is basic. In terms of decay, if any part of this tooth is eaten up or it rots, that is what we call tooth decay. Or if the enamel has any disease, it will show in terms of changing in color. So basically that's the structure of a tooth. It is the same from the front teeth to the back, milk teeth, permanent teeth. They have enamel, dentine, and middle. Yes.
Okay, I'm just sharing. Yeah.
I have started screen sharing. Let me see what.
Oh, sorry. Did you want to? No, I was just recapping the parts of the tooth.
So in terms of.
I think there's a delay. Should I stop sharing this one?
Yeah, that's a good illustration of the enamel, dentine, the pulp. Yes. Yeah, so in terms of when I look in the mouth as a dentist and what I see, that will tell me that there's a problem. That will tell me that there's a problem with your body. Most of the time, the gums.
Wait. How?
Sign that there's a problem.
I think there's a delay. How? Let's just go through. Let's go through the routine, like what Lois said, as in what do I need to take care of my teeth regularly and all that. Then we'll go to the systemic effects after. Like what should I do? How many? The checkup. Who should I see and all that stuff. You are on mute.
Okay. So I'm trying to reduce the number of things online so that we stop hanging. But basically, it is highly recommended that you visit your dentist at least bare minimum once a year. Twice a year is good. At least once a year is very important. At this point, what we usually check for is cavities. We usually check for any diseases of the gum. We look at the mouth, all the tissues, so that we can check for any diseases, any ulcers, anything alarming that we would need to take care of. You know, the thing about this mouth is that we use it every day, all day. Anytime you're talking, you're using the mouth. Anytime you're eating, every single meal you take, almost nowadays it's no longer three meals a day. Nowadays it's standard five meals a day. When you wake up in the morning, you'll take something. At 10, you'll take something. At lunchtime, you'll take something. At 4, you'll take something, and then in the evening, you'll take something. So our teeth never sleep. The mouth does not rest. So if this was a car, let's say, because if I were to apply it to daily life, and we know a car, we know that when you use a car, you need to keep servicing it, otherwise your engine will knock or something like that. So same with the mouth. If you don't take it for dental checkups, if you don't take it for service, cleaning, you'll end up with a problem. So that is the basic gum disease and dental caries or cavities. So it is recommended. I feel that once a year is kidogo, but the assumption is that we brush our teeth daily. We brush twice a day, in the morning after breakfast and at night before we sleep. Most Kenyans have this habit of brushing their teeth before breakfast. Now I can't talk, I can't do anything before I brush my teeth. So they'll brush their teeth and then they'll take breakfast. So that means on that day, your teeth are clean for only like 10 or 15 minutes. After that, they'll be exposed to chafu until evening. Hopefully you'll brush your teeth in the evening before you sleep. Otherwise, if you don't, the teeth will still be exposed to plaque and uchafu till morning. Then you'll brush, then they'll be clean for only 10 minutes. So in such a mouth, by the time you're going to see the dentist after 1 year, you'll have cavities, you'll have gum disease, and then you'll keep saying, me, this dentist of mine is not helping me. Or maybe my toothbrush is bad, or maybe my toothpaste is bad. But at the end of the day, you find that it is you and your habits which are leading to these diseases. So basically, I recommend that you brush your teeth at least twice a day, in the morning and the evening. In the morning after breakfast, at night before you sleep. And then if you take anything at 10, you have to rinse with water and make sure the water goes in between your teeth. If you take lunch, rinse with water. If you take anything at 4, rinse with water. Whichever snack you take, you have to rinse with water. Make sure the water goes in between the teeth. That way you'll be able to keep your teeth for a lifetime. Because at the end of the day, all of us want to have teeth at retirement.
And what about flossing? What about flossing?
Flossing extremely.
Sorry, by the way, can you send us those
like
things?
If I were to use my model again,
I'll send you floss. There are so many over here, my God.
Yeah, so when we brush our teeth daily, let me see. When we are brushing, the toothbrush cleans only the surfaces. So this is an outer surface. There's the inner surface over here. And then you know how we brush, right? So what are the chances that this toothbrush is entering in between your teeth to clean? Rarely or hardly, unless you have very spaced teeth, right? So the floss comes in because now at least the dental floss is able to clean in between the teeth. And of course, when you come to see a dentist, the machine cleans what we see, and also a lot of tartar comes out from in between the teeth, because these are very nice spaces for uchafu to hide, yeah? So basically, flossing is very important. It's a difficult task for most people. So I recommend at least twice a week. So you can imagine you're sitting there, in front of a mirror with dental floss, trying to go through all the spaces in between the teeth. People get tired. So I recommend that you use floss when you're watching TV, or when you're watching news. That one, those are very convenient. Thank God for whoever came up with that.
Yeah.
Yeah. So You can just, whatever, when you're watching news or something, you can just pass the floss between the teeth absent-mindedly, but it works at least twice a week. That helps. So there's the floss that you put in between your fingers, and then there's what you have shown us.
But they have both. Floss. Let me ask, Ashoma, please bring that long floss, you know, the one we get free from the dentist. Yes.
Yeah, so the floss picks, the floss picks, the challenge is that sometimes people hurt their gums in the process. So sometimes managing the force is an issue. So you find that they hurt their gums. But yeah, at least I can see you are well stocked in that house, and I hope you use it. It's one thing to own, but most of the time
I floss every day.
Every day.
Okay, not with this one.
Not only when...
Okay, this type comes as a string. Are you seeing there? I'm struggling to. This one we get. It's the point, what I call point of privilege in this country, because I have a dental cover. So this is free. This one, I go to the dentist twice a year. I mean, with my 35 cavities, but half my teeth have cavities because of the years of abusing Coca-Cola. Yeah, they owe me Coca-Cola and tea. So I have, and oh my God, it has opened. So here is the string one.
Yes. So it would demonstrate to us how you put it.
I'm not flossing my teeth over here in front of people, no. But it's basically what you do with your, you know, that sometimes you pull an Uzi from your item of clothing and you just go in between. Okay, I'll use the big gap because it's there. You go in between, up, down, and then just it's disgusting, but it's very helpful for me being a dentist. Helpful for your teeth. And also the other Kenyan habit, you know, the mswaki, the thing like my father uses the mswaki thing in between every meal. That is also right, it's legit. Cindy?
Yeah, it actually helps a lot. It helps a lot. It stimulates saliva, which is what we need a lot of. Yeah, and it's better than nothing.
Yeah. Okay, and would you kindly demonstrate how to properly brush the teeth? Because I discovered most of us don't know how to do it, and what amount of toothpaste and what kind of toothpaste should we?
Okay, Sawa. So in terms of the toothpaste, the most important thing is the brushing and to reach all the surfaces. The toothpaste makes it a pleasant experience. It adds some flavor, and it's something that we have gotten used to out of habit. If you compare it with the mswak, there are those who are used to it. The effect is literally the same. So the toothpaste, unless it has some benefits like maybe extra fluoride and things like that, it's not super duper important. The important thing is that this toothbrush reaches all the teeth surfaces one at a time and removes whatever food remnants are there. Because you see, when food is left there, whether it's a piece of bread, whether it's a very small particle, it mixes with saliva. The saliva has ions, it has minerals. So the minerals make the food particles become very hard. So that if it stays there for some time, you find that no matter how hard you brush with this toothbrush, it won't come out. So that's what we end up calling tartar. And by the time it's tartar, we can actually see. So after every meal, if you rinse with water, the water helps to clear out the food remnants. And then in addition, when you brush your teeth, the toothbrush scrubs out whatever food remnants are there. So there's what we were taught when we were children, like brushing teeth is like scrubbing, it's like brushing shoes, yeah? And we will do front-back movements. But in the end, you find that those movements really injure the gums and they injure the teeth. So it's recommended that you brush in round movements, yeah? So the technique is that you try and do round movements, and in places where you can't do the round movements, you just do strokes that literally just remove any food particles that are there, but try and avoid the excessive scrubbing. Yeah.
Okay.
So the dentist, I'm assuming that your people see the dentist at least once a year. The dentist will be the one to best recommend or teach, or the hygienist in your case, teach how to use the toothbrush. Then there's the soft toothbrush. There's the, the hard ones, not recommended. A medium toothbrush is okay. Then, of course, when you're buying a toothbrush, you look at the bristles. When they are flat like this, there are areas where you miss. So it would be good to have some with which reach interdentally. Where the toothbrush is not able to reach, of course, the dental floss will help. Yeah, and
for we of land of privilege, the difference, because when I go to the dentist, she always recommends an electric toothbrush. Is there, in the mechanics, what like if I have Bill Gates kind of money, what kind of toothbrush are you recommending to me vis-a-vis my grandmother in Eshishevu village?
So toothbrushes are different. Even when you go to the stalls, you'll see that there's one which shows that it cleans interdentally. There's one which is soft. There's one which is a smoker's toothbrush. There's one for 3 to 5. Like every single toothbrush has its own work. Yeah, there are those which massage the gums and things like that. So for me, I prefer, this is my personal preference because it works and it makes sense. I don't have just one toothbrush. Most of the time you find I have 4 or 5. So there's one which cleans interdentally. There's one which cleans at the back, which says it cleans even the wisdom teeth areas. There's one which massages the gum. There's one which has a tongue scraper. There's one, So at the end of the day, the objective is to make sure these teeth are clean. Yeah. And whatever you use, it's like clothes. Yeah. There are those who use a washing machine. There are those who clean their own clothes. There's those who have mama fua. At the end of the day, you just want clean clothes. So whichever works for you, or whichever preference it is for you. In the case of clothes, the soap, everyone has their different preference. So even for the toothpaste, whatever works for you, fine, as long as you follow the routine, which is brush after meals and before you sleep, and brush consistently and rinse in water. Yes.
And how often should we change our toothbrushes?
That story for after 3 months, I find that it's a marketing thing, honestly speaking. But we say every 3 months, you change your tooth. Do you change your toothbrush every 3 months?
I throw all the toothbrushes in this house every 3 months. But you see, I come from a point of privilege. I get free toothbrushes, and you can even get a toothbrush for $1.
Okay, so in terms of toothbrushing, what I would say, when you look at your toothbrush at the bottom here, I don't know, there's the bristles, and then over here at the bottom, most of the time you'll find that when you look at the toothbrush, there's a very sticky, I call it very yucky layer of toothpaste that has solidified there. I advise patients to soak their toothbrushes. Or if today, just go and look at your toothbrush. If you don't soak it, you are introducing bacteria and many other not nice things in your mouth through that toothbrush. That is one maintenance thing that I say. The second thing, what was I saying? Oh, the dog. Yeah. So that's then you had asked me about the electronic. The electronic is fine, especially if you don't have fine movements. There are children who have not attained the age where they can do the brushing movements. Then there are those who, for one reason or another, maybe there's a stroke patient, they are not able to do those movements, that the electronic toothbrush comes in. And then the electronic toothbrushes also, they have different types. They have different movements. The ergonomics are different. So there are those which just go round. There are those which go round and they go in between the teeth. So it depends at the end of the day. As long as that toothbrush is going on every single tooth, you're not missing your wisdom teeth, you're not missing the insides of your teeth. That's what matters. Yeah, and the consistency.
And what about the activated charcoal and bicarbonate of soda and hydrogen peroxide? You know, these things that we Kenyans just put on our teeth because it's the next thing that's fashionable. Are they recommended?
So everything has to be standardized. If you buy the one which has gone through the standardization processes, and we know how many, the size of the particles, and we know all those things, that one is okay. Some people use charcoal. You find that the charcoal particles are so big, they end up rubbing off enamel, and then that creates a new problem. The peroxide, peroxide can burn. So the dilution is very important. When you don't just pick and just because it's written peroxide, you start using. So those are the things that you need to research on before you start using. Of course, there are some scientific benefits, there are medical benefits, they actually work. It's called what? The toxin pulling ability of charcoal is very good in the mouth. So there are benefits, but you don't just pick anything and use. Pick what has been tested and recommended for use for that particular activity. Yeah. Yes.
Okay. I think, Lois, unless you have a question for her on Martha's teeth, we can go to the systemic part.
I just wished she would talk a little bit about the tongue and tongue brushing. Because I feel that's a part where people miss a lot, and we have a lot of bad breath going around. Thank God for masks in the recent few months. So I think that's an area that people need to be taught about, maybe. How?
Yes, for sure. It's part of the daily brushing. Brushing the tongue is very important because number one, when you brush the tongue, as you have said, it prevents a lot of halitosis, bad breath, and it's just good for the freshness of the mouth. Then apart from that, looking at the tongue, do you know how many, we never look at our tongues unless maybe you have trauma and you have hurt yourself. That's the only time you look at the tongue. So if you create a habit of brushing your tongue, you'll have more opportunities to have a look at the tongue. And if there are any changes, you'll be able to tell. Because most of the time, unfortunately, when patients come and you notice something on the tongue and you're asking them, how long has this been here? Then they're like, oh, there's something there. I don't know. Do you look at your tongue? No. Unless I'm hurt, I never look at the tongue. So that is a very important thing also to say. And then of course there's the brushing. Some toothbrushes have tongue cleaners at the back. Then there's what we call tongue scrapers. It's an instrument you buy, then you scrape your tongue. And then also some people, there's something that is similar to dental floss that you use also to scrape the tongue. Yeah, so that is important. And then of course I will need to mention gargling. We have a habit of using mouthwash after brushing our teeth. Mouthwash, I'm not being alarmist and I'm not being against the manufacturers, but mouthwash should be a prescribed medication. I know we buy over the counter, we go to the supermarket and buy, but there's the normal flora, there's the normal balance in the mouth that is there naturally. So every time you use mouthwash, whether it's chlorhexidine based, whether it's alcohol based, if you use an alcohol based mouthwash, you're drying the mouth. And when you dry the mouth, of course, there are consequences. Every time you use mouthwash, you dry the mouth, you end up getting stains, you end up getting accumulation of tartar if you don't take enough water. If you use a chlorhexidine based mouthwash or betadine, after some time, your teeth start staining. So in the process, you're creating a new problem. So most of these things, I think every dental care routine should be personalized, and you should not just do it the way you feel. I think you should do it in conjunction with your dentist, your personal dentist, and then that would be what I would recommend in terms of.
So where did we pick up the habit of using mouthwashes? Then, if it's not a dental, I don't know. Where did we pick that habit from? Is it because of the advertising?
I don't know. You know, people treat bad breath at home.
Okay.
Yeah. So they do whatever it takes to sort out their bad breath. And then when it doesn't work, that's when they go to the dentist. Mouthwash is the easiest, closest thing that we are used to. When you don't brush your teeth, you reach for the mouthwash. When you feel like, I'm not feeling fresh, you reach for the mouthwash. So it's something that is there. It's available over the counter. It's available in supermarket aisles. Next to the toothpaste, there's mouthwash. So if I am privileged and I have the money and I'm seeing, mouthwash, and I've been seeing on movies, I mean, if I can afford it, why not? But at the end of the day, even the process of choosing that mouthwash should be at least with the advice. You should get some medical advice out of it before you just start doing it. Yeah. But as I said, that is something I have seen. People don't talk about it enough, but even just from a medical perspective, it is not right. Yeah.
Okay. Yeah, because I think it also flushes out the fluoride from the toothpaste, which is supposed to be protective to your teeth. Cynthia, at least I read.
Good student.
Okay, let's go to the system.
We'll not try. Yeah. But also the mouthwash, it might be having fluoride. So it might you see, mouthwash has different things. If you have a fluoride mouthwash, it's still beneficial. So, inalingana.
Yeah. The sharing of the screen is the hardest job on Zoom. Okay, just give me a minute, because your screen.
But we can see your screen.
Yeah, the screen literally disappears. You don't know if you're seeing. Okay, are you seeing now?
Yes, we can.
Yes, okay. We can see.
So because this is a layman, whatever, there are so many gory pictures which would have been a nice story, but because we are showing the public, we have to go soft on them. So Lois, now we move back to you. Let's start with the diseases that show up in your eyes that a manifestation of something else that's happening to the body. So we start off with the outside in. I think that's what we decided on. So let's start with the eyebrows, the hair part, the appendages. Okay, go ahead, please.
Okay, so from this picture, I don't know whether you can see my cursor or it has to be your cursor.
I can't see your cursor. Yeah, I can't. I don't think Facebook.
So this is the extreme right top picture that has white eyelashes and eyebrows and white patches on the face. Yeah.
Yeah.
So that could be a sign of a skin condition we call vitiligo. Usually causes loss of skin pigment or just color, either on your hair and on your skin mostly. And the most common presentation would be facial and involving the hands. Okay, so this could be vitiligo. I don't know what your picture said it was, Dr. Aswani.
I don't know what it said. I just picked pictures random from the whatever. I didn't look at the disease. The ones that are obvious are here, but that one, it looks nice. That's the reason it made it there.
Okay, then there's the extreme left top picture in the screen. Yeah, this one could be xanthem.
Oh, this one, the one in the middle.
Yes, it could be just.
It's xanthelasmas.
Yeah, it could be lipid accumulation, and that person, if someone has such things, the most important test to get done would be maybe their cholesterol levels checked, so that just to ensure that their cholesterol levels are in check. However, it could just be a skin lipid accumulation, but you need to have your cholesterol levels checked if you have such skin lesions. Then there's the extreme left bottom picture, which I think also the two pictures for the two ladies could be meaning the same thing. So you can see that glare-like look. So, you know, originally or normally, you're not able to appreciate the top white part of your eye, if you know what I mean. Yeah, the scleral show, that we call the scleral show. So basically, this lady with nice braids and a white hairband has an alert look. And this is someone who needs to have their thyroid hormones checked, the thyroid hormone levels checked, because this could be what we call Graves' disease, which usually is a reflection of a high thyroid activity. So your thyroid hormone levels could be higher than normal. However, there is what we call euthyroid thyrotoxicosis. Basically, your thyroid hormone levels could still be reading normal, but you have this hyperthyroidism kind of effect. So, but this patient, the first place to start would definitely be the ophthalmologist, so that we stop this whole, the drying effect of the scleral show. But the other most important person that this person needs to see is the endocrinologist, or just in our setup, just a regular family physician would do, so that they get their thyroid assessed and the appropriate attention given. That's it for those pictures. So we move on to another one.
Oh, you can't see the ones on the extreme left? Okay.
Oh, I thought there's a way you're going to bring them to be the most...
I tried. Trust me, I tried.
Okay, so this picture...
Yeah, because the next goes to the eyeball itself. Okay, they can't...
What's in this picture? Is it like a hypopigmented
the one on the
area?
top?
Yes.
No, it's like alopecia. You know, the one, totalis?
Oh,
yeah.
There's totally no eyelashes and no eyebrows.
Yeah.
Oh, there's no butterfly-like picture also, where the SLE people would fall in, like they get that butterfly picture.
I thought that's a skin person thing, or not an ophthalmologist. Okay, let me look for it.
I don't know. I appreciate the no eyelashes and the no eyebrows.
Yeah, no eyebrows, yeah.
But there has to be a skin condition that's leading to this.
And sometimes alopecia totalis just, it's about
alopecia totalis.
Yeah, it's just shit happens. Like there's no reason. It's an autoimmune thing, like the same way, what is it called? The hypopigmentation for what did we call it? It's just an autoimmune thing that just targets your hair, and there's nothing we can do.
Yes, so this person basically has a skin condition. Yeah. So this is a dermatology patient. Yeah, that's not an ophthalmology patient.
Yeah, but
only that now they show up to us because they don't have eyebrows and eyelashes. And I can promise you there's nothing we can be able to do to bring those eyelashes.
No.
Unless now the dermatologists have something that they give to stop the autoimmune process, and so that now the eyelashes can start to grow. Then there's this patient who I'm figuring out like they could have a facial nerve palsy. So the second picture and the third picture, because they are unable to close their eyelid on that left side.
Yeah.
Yeah, and they have a drooping eyelid also on the left side. The upper eyelid, when they open their eye, they're not able to open completely. Yet when they close, they're also not able to close completely. I'm guessing this patient could either have a stroke leading to a facial nerve palsy or a Bell's palsy that's causing a problem with the eyelids being able to close correctly.
Yeah, or a tumor somewhere.
Or could be a tumor, yeah. Could be a tumor that's causing a facial nerve palsy. At the end of the day, you have to trace why is there a facial nerve palsy. Is it something as simple as Bell's palsy, or is it tumor related, either in the parotid gland area or intracranial tumor?
Okay.
Yeah.
The eyeballs, the pictures that are out there were scary, so this is why I chose this nice one, these ones that are a bit lookable.
Okay. The first picture where the arrow is showing, we call this this condition what Arcus senalis. Okay, so it could be a sign of old age. Yeah, when people are aging, they get that white ring at the area of the peripheral cornea. But it could also be a sign of some patients who get this when they have recurrent ocular allergies, and so they get a pseudo ring, okay, because of the inflammation that would show up coming from the conjunctival region, going to the clear part of the eye, the cornea. And then when it heals completely, you get now that pseudo ring. But some patients also with high cholesterol levels would get that ring earlier than their age. So it could be three things. It could be people who've had allergies in their childhood that has now since settled. It could be old age, or it could be people with high lipids, dyslipidemia, causing a white ring around their eye. Yeah, so that would be cholesterol accumulation around that iris or mostly the corneal stromal area. Okay, now the retina pictures. So the top part is a normal retina picture. This second picture, Dr. Aswani, what is it?
Like I said, is when I picked it, so I don't know what it is. But the reason I put this slide also is to remind me, you know, the systemic diseases, the metabolic conditions, and sickle cell, why they need to have a retinal examination.
Yes. Okay. So what I'm guessing in the second picture would be the white particles that you see in the second picture. Those could be in the vitreous. Remember the picture on my slides on anatomy, and there's the vitreous jelly. Usually it's clear, but you have people who get something we call asteroid hyalosis, which is white or yellow particles within the vitreous cavity. And usually the vitreous would be clear. So if you took a picture, a fundus picture with that, you probably would end up with such a picture. So the white or the yellow particles that you're seeing floating on that retinal picture could actually be in the vitreous. And asteroid hyalosis could be a condition that doesn't necessarily have a causative factor. Again, people with dyslipidemia could also get asteroid hyalosis. So dyslipidemia would be one of the things that you would have to check out for in such a patient, the patient with that picture of the retina. Then there's the bottom left picture, which looks to me like a picture that has a corneal ulcer. Now, it would be very nice to talk about corneal ulcers, Dr. Aswani, because corneal ulcers can have systemic indications. I mean, systemic
manifestations.
There could be manifestations of a systemic disease, mostly
like part of Reiter's.
Reiter's.
Yeah, the one that has your penis, urethritis, uveitis,
okay, but that one would cause mostly a conjunctivitis, basically very red eyes, red eyes. CVD, that's what cardiovascular, no, not cardiovascular disease. What is it called? The one for collagen vascular diseases. So patients with collagen vascular diseases, sometimes like rheumatoid arthritis, Wegener's granulomatosis, even sometimes SLE, will present with corneal ulcers first before you actually pick up that they have raised ANA levels in their blood. Because when they present with now what we call autoimmune corneal ulcers, then we will send them for all those tests that maybe the rheumatologist would also send them for. And when they come back, sometimes we are able to pick up the collagen vascular diseases or collagen diseases earlier than they would have if they waited for the systemic symptoms to show up. I don't know if that makes sense.
Oh, it makes sense. And I've never even thought of that.
Oh.
No, I've never thought of that part of system of the importance of an eye exam in those collagen diseases and the autoimmune diseases. Thank you.
Yeah. So, by the way, if you have any of those patients in your care, you need to send them to the ophthalmologist for an assessment. Recently, I got a patient who is being managed for rheumatoid arthritis. So that patient is on a myriad of drugs. And one of the drugs is actually causing her very dry mouth, very dry eyes, very dry nostrils. So this patient, because of the very dry eyes, ended up getting a corneal ulcer that was actually perforating the eye. So you basically can lose the eyesight of that patient because of treatment for the collagen disease. That's one. Or number two, the collagen disease itself can cause such dryness of the eyes that they end up getting very bad and very rapidly progressing corneal ulcers that actually perforates the eye. So your slides don't do me justice, because an eye perforation is a whole, an eye perforation is a whole different paradigm that is sight threatening. Yet it's something that can be maybe completely avoided if the systemic doctor worked in collaboration with the eye doctor and vice versa.
I think they're not, okay, I'm echoing. I think they're not aware, and also, you know, the territorialness we have, like, this is my patient, I don't want to be seen that I screwed up. So sometimes people don't share that. They don't do what we call curbside consultations over here. And and that's a place you and Hawa would collaborate, because you see the dryness causing all that stuff. Also the xerostomia and the dry mouth causes other issues in the mouth. I hope she'll touch on that. Yeah,
that's true. Okay. That's true.
You see 4 slides, 4 pictures, and they triggered all that. And you're complaining.
Yeah, 4 layman kind of like picture, public health.
Yeah, it's very public health. If this is not a scientific conference, okay. I think you're
Hawa, please take over.
Hawa Kuja, yours were even worse, so I tried. I tried. They were terrible. I was like, I can't put those things up. Yeah. Okay, go ahead. For the lips, and you can go systemic as Lois has done. I tried. Mkinipea macho mbaya. Okay, go ahead. Yeah.
I'm sure mine would have been very terrible. So you've tried.
Public health. Muniskizange.
So from the first one, I can see some hyperpigmentation. Hyperpigmentation means that there are areas with darker spots. And actually, sometimes patients come and they say, my gum is turning black. And if someone assumes that's just a normal African color, you may end up missing out on a few syndromes, yeah? So one of the things that presents like this, like hyperpigmented gingiva, is Addison's disease, which can be missed. And then hyperplasia of the gingiva, what am I talking about? Melanocytic.
Wait, see, gingiva and gingiva. Lois, ulikuwa unajua ni gingiva?
Hapana, mimi nasemanga gingiva.
Ni gingiva kihawa, ni gingiva.
Tuende na gingiva. Mnaisiitaje? Gingiva.
I'm so sure it's gingiva. Lakini sasa Uluya. Okay, go on. I'm sorry.
Gingiva. Yeah, so melanocytic pigmentation on the lips and the buccal mucosa, like what I can see here. The buccal mucosa can't be seen much, but it can show Peutz-Jeghers syndrome or disease because of multiple intestinal hematomatous polyps. In short, what we are saying, this is something when we see, we refer you to your physician to investigate you further. It's not something we ignore that. Now maybe I'm getting new birthmarks. No, if you have that, go and get checked out. The third one, I'm not sure what I'm seeing, but it looks like
you know those lips that look like you when you like they have eczema of sorts. That's what it looks to me. Those guys who lip, the lip dermatosis because of licking your lips too much. But I don't know if it causes a systemic thing. If there's a systemic thing that looks like that.
Well, systematically, most of the time, patients with anemias, they present like this. And also, in addition, they usually have cracks at the edges of the lips. And that shows. Then they also have the tongue. Now these tongues, there's a red one. Let me assume that this one down here, well,
the one labeled B.
Yeah, the one labeled B. It's beefy red. When you have a beefy red tongue, it's a sign of vitamin B deficiency. Actually, pernicious anemia, vitamin B12. So patients with beefy red tongues, they usually look like that. Or you can have a glucagon secreting tumor, a glucagonoma. So that can also be one of the causes of a beefy red tongue. The next one, a big tongue or macroglossia. I have a very big tongue, by the way, but I don't have any of these. So it doesn't mean that if someone has a big tongue, they have these, yeah. But I'll assume this is a big tongue, macroglossia, and it can be.
Let's go with smooth.
No, the smooth one, it's a different one, yeah. So it can be a sign of many things, like it can show multiple myeloma, lymphoma, amyloidosis, hypothyroidism, angioedema, acromegaly, or Down syndrome. So it can be anything, but it's a window. Like it can show any of these as one of the signs, yeah? So for the very smooth tongue, which we call, it's like a bald tongue. The tongue usually looks hairy. So this one, it's referred to like it's a bald tongue, which shows that there's a bit of atrophy of the papilla of the tongue. It can be a syndrome. It can mean that you have maybe pernicious anemia, iron deficiency anemia, xerostomia or dry mouth in children, and pellagra. So those are some of the things that, I mean, those are hints that most of the time when people go for medical checkups and the doctor says, let's open your mouth, put your tongue out, we think it's just routine. Or most of the time we assume we are looking at the throat, but also the tongue can be a very good indicator of many of these things. Yeah. The lady at the end, it's also characteristic of a bit of anemia, but I'm not sure. Most of what I've described should be on that.
She also looks like she has, that's scleroderma, because that mouth looks tight.
Mm-hmm.
Even her skin, because this is an old white woman, their skin, unless they're on Botox, doesn't look like that. Yeah.
Yeah, I agree. Yes.
I just want us to go back to the tongue labeled B. And in the era of COVID, because my passion is teenagers and that's pediatrics, some of the children just presented with this because if you guys remember Kawasaki's, and there's something called MISC, which is multi-inflammatory system condition, something. The full and part of it was it's just okay. And step 2 medical boards here. This features a lot because it's an indication of an inflammation of an inflammatory condition caused by a virus. So there's Kawasaki's, and now with COVID, pediatricians have been seeing this. So when you see a child with a red tongue, don't just think alilamba eyes, yeah, red. I'm a mabuyu. Mm-hmm. Yeah, okay. I tried.
Right. I'm seeing Kaposi's.
The bottom, on right?
The palette, and the bottom right, there's a lot of whites, which it's called what? Lichen. It can be, so anything white. Let me start from the top. This is an indication of Kaposi sarcoma. In HIV patients, we see a lot of this on the palate. It's an indication of that. And then there's now white stuff. The white can either be oral candidiasis, it can be hairy leukoplakia, and it can be lichen planus. So, of course, there are differences. If you can scrape it off, most of the time it's candida. If you can't scrape it off, it's oral hairy leukoplakia. And usually it's seen in HIV patients because of course, Epstein virus. And then when you have white lines on the tongue, do I see a tongue here? No. When you have white lines on the tongue, mostly it's lichen planus. So leukoplakia is benign, but erythroplakia, if you have a bit of red and darkening, the same lesions, but when they start changing, then you have chances of getting carcinomatous or cancerous lesions. So those are things basically seen in HIV patients most of the time. Yeah.
And also the lesion at the top, because inappropriate. Sometimes if you've had penile oral sex that was a bit forceful, there can be an imprint that looks like that on your palate when you go to the dentist the next day. So you have to be careful of the nocturnal activities or day activities you engage in before you go to the dentist. You know, my mother would be mortified it's Sabbath, but yeah.
Yeah, for that one, it would not have the bumps that are seen. It would look traumatic. Traumatic injuries are very characteristic. Yeah, but yes, yeah.
Oh. And because the jaw, yeah, I think that this is the last one. The jaw is also it's a shared. Is it a shared thing between you and ENT? I don't know who owns the jaw, but yeah, just talk about the jaw. You can use this guy or any other. The other pictures were too gory.
Okay, so the jaw, this one, I'm assuming you just picked any picture, but from here, there's the jaw is protruded, what we call a prognatic jaw. It is pushed outwards. The features on this person looks like a bit of gigantism, acromegaly. So the jaw will be an indication. Jaw growth is an indication of such conditions. Of course, this will be hormonal. We will refer for a review of the hormones, especially if a child comes and they are just beginning to have such symptoms of excessive jaw growth. That will be an indicator that will help a lot in such cases of acromegaly. The other thing, gosh, my data is almost over.
Oh gosh, Chatuma pesa bundles.
What I expect. Yeah, the jaw generally is a window into that. Let me stop at that and recharge before it goes. Yeah, but you've understood, eh?
Yes, and I think we've covered the whole from the eyebrows to the jaw, we've done well.
Mm-hmm.
Yeah. Okay, let me stop sharing. Okay.
Wow.
Yeah, but I've really enjoyed this thing and I've learned a lot. My gosh. Okay. Do you have questions for each other and for no one ever asked questions for me? Yeah, but do you have questions?
Maybe it should be from you asking us whether there is something we needed to clarify that we have probably missed.
I think we've gone. Whenever I need clarification, I interrupt. So
Okay.
yeah, so I think we've covered basically what we need to do and the systemic manifestations. We can't cover everything because those are 35 books. But yeah, the ones who will watch this later should benefit. So the take-home message for you, Lois, is I have to go to judge. What's your take-home message?
So my take-home message is get your eyes checked at least once a year. Get your children's eyes checked at least before they join school. And the special indications of a must get an eye check would be children with a squint and children with a white reflex. And for adults, if you've had your sibling or your parent or your grandmother go blind unexplainably, like there was no trauma, there was no cataract that was operated on, it would be nice to also get your eyes checked as soon as you turn 30 and beyond, because then we can be able to catch a lot of things that we can avert the gross outcomes, which in our case then would be loss of sight. If we catch it early, things like glaucoma, we are able to curb them or to stop them from making someone go blind. The other mention would be people with systemic illnesses, the diabetics, the hypertensives. If you've got rheumatoid arthritis or any autoimmune disease, just get your eyes checked.
Yeah. Okay. How are you? What's your take-home message?
Yes, this has been very informative, especially the eye corner. I'm very happy. The take-home message would be the dental checkup is very important. Most of the time we do it just because we have dental insurance. So most of the people who don't have dental insurance assume that they cannot afford a dental checkup. The most, I would really advise people to go get a dental check, because the highest, I don't even think people charge 5,000 shillings. Like that is the highest I can imagine a dentist charging for consultation. Most of the time it's 1,000, 2,000, and it covers for the whole year. Public hospitals will pay like 300 just for once a year consultation. So mine will just be to encourage people to go for checkups, continue with routine daily hygiene. We are always saying sweets are bad, chocolates are bad, but we are always consuming. We are giving our children, nowadays when we give our children those sweet things, it's a sign of love. If you don't buy them sweet things, it means you don't love them, which leads to other things. So one thing I would emphasize is we are in the age for wellness and taking juices, and these juices are acidic. This is something most people don't know. When you keep sipping on your juice, you put lemons inside your water, you keep sipping the whole day, you are eroding your enamel. In a few years' time, you'll have extreme sensitivity and you'll keep wondering why. And by the time you have that, it's too late. Like once you lose enamel, it's gone and gone for good. So I would recommend that continue with your nice juices, but rinse in water after, and don't keep sipping. Just take it within 20 minutes, that will help. And then of course, our children, let's start early, brushing their teeth. By the 6th month, when the first tooth pops in, start brushing. You can start wiping the gums with a cloth when they are still breastfeeding. Yeah, and all these things will be told by your dentist. So at the end of the day, I can talk and talk and talk, but visit your own personal dentist and get checked and get advice. Yes. that would be my take home for today.
Okay. Me, on the policy side, I would want Snellen charts in schools. And I think in Kenya, we also need to adopt the eye check before you get a driver's license, because this is why I have my machichios over here. I came to this country with a 2020 vision, but because of middle age, so here you have to do an eye check every 5 years when you're getting every 4 years when you're getting your driver's license, because apart from just sleep, alcohol, bad driving, the other major factor that causes poor driving is
poor eyesight. That's a good point, Dr. Aswani. Yeah. That's something that should have been adopted from the onset of giving out driving licenses. Yeah. But like you said, we live in a country where policy is at the back of, I don't know, it's in drawers or something. It's
I think
there.
we just
I'm sure if you read the driving policy, it would be there.
Yeah.
But no driver, I can tell you, I've practiced ophthalmology. This would be the 4th year now. Nobody has ever come because they're getting a driving license to get their eyes checked. Never.
And I think, okay, now we see we've gone on a tangent. Inaenda kanisa, so mkumbuke your part. So, and because of I should show you outside, it's so cold. So we have to warm the car. Kabla uingia, otherwise you're just gonna die of the cold. Oh. It's negative temperatures in Fahrenheit at 60 degrees Celsius. Anyway, it's not, whoever will watch
the best in surviving that. We are dying of heat. We are currently at 27 degrees.
Oh my God.
Let me tell you, it's hot.
I don't think I can survive in Kenya anymore because of getting used to the cold. Anyway, where was I? What was I talking about? Okay, I'm telling you.
Policies. You're going to church. Now, where are we?
Anyway, let me just say, I think we need to take like I said, the bull by its horns. We need to just start this. Oh yeah, I've remembered my point. You see these Kukena circles, you can tell I was in Kerugoya. All these circles, all these matatu circles, all the bus drivers, all the long distance drivers, they can start with them. Like make sure kabla upate drivers PSV license, you know how to, your eyesights are checked and someone logs your sleep. We will reduce, because sometimes you think people are drunk. No, they were not seeing and they were sleep deprived. You can tell I hang out around sleep specialists for too long, right? Yeah. So in terms of, and we can do these things ourselves, because what was Zimio and what's the other slogan, na wheelbarrow will not help us. We just need to accept that part and move on. Like just change poco a poco, and we will get there. I'm so grateful. I'm so thankful. I will pray for you when I'm in church today.
Yes, please do.
I will pray. Unless I still go to church on Saturday, despite Mekichangumu.
Well done. Well done.
I still do. Asante sana Hawa. This was, I wish there were more. Okay, I hope, I'll send you the link so that you can sambaza. This was very, very informative. I like learning. I love. And Lois, if you remember, Hawa came to give these talks. I was at AAR a long time. You remember they used to organize? I didn't start.
You actually organized those CMEs routinely. Yeah. Well done. Well done for keeping up.
Yeah, and Hawa has been, I was talking to Sai and I was like, yeah, you and Hawa and Sai is my brother. I've always dragged them along. Thank you. Because I think dental and ophthalmology health, I was going to get a skin specialist, hakujibu text yangu. Nitampea tu machombaya, lakini it's underappreciated, but imagine, look at what we've learned in 1 hour, 20 minutes, I think. Good job, girls. Good job.
Thank you.
Okay, and where do people find you, Lois? You're in private practice, where again?
Okay, I have a private practice coming up along Kiambu Road. It's called Opti Eye Clinic. But currently, you can also find me in Kikuyu on Tuesdays and Wednesdays. I do theaters on Monday, so that would be completely out. But I'm in Kikuyu Eye unit on Tuesdays and Wednesdays, whole day, really.
Is the line in Kikuyu shorter? I was in Kikuyu for internship, so I'm asking from a point of knowledge. Is the line there shorter?
The line is not shorter, but it's quicker because we are more.
That's good.
And we are very intentional on getting people seen as early as possible. So let people not shy away from coming to get their eyes checked because of fear of the queue. The queue moves really fast. So the thing is, we haven't gotten to a point where the clinic runs on appointment. I think that would be the eventual success for that clinic. So what happens that everybody, because they have that mentality that the queue is long, they come very early. So by the time I get to work, 90% of the patients that will be seen in that clinic on that day have already arrived. That's what makes the queues long. So our mornings are extremely busy. But what's
the hindrance of getting appointments? Because that works very well here. And the Kenyans who come here adapt.
Now, Dr. Aswani, you agree with me that the most part of the country is not as exposed, so to speak. Yeah, so we don't have the habit of calling before going. If we would absolutely adopt that, then it would be easy to implement an appointment kind of clinic, because then it would be important. It would be very nice for me to walk into the clinic and know that today I have 40 patients booked under my queue. Yeah, it's something that I don't know where we would start. Would we start from the patients? Would we start from the management? I don't know where we would start. I am stuck. I just know it would work better if we implemented an appointment kind of clinic. I just don't know where to start. And I'm not in management yet, so I don't know yet. I don't have an answer.
Hawa, if you're still listening, where do people find you? Okay. Oh, yes. Okay, I think she's rejoining.
Okay.
When I think through the appointment system for a public, for Kenya, I will let you know, because it really helps. When,
and then improve care. Completely.
And are they electronic or it's still paperwork?
So it's partially electronic because everything that's done is logged into the system.
Okay.
But I still write notes. It's not like we did it in AAR where we saw patients on a system. No, I still write notes on a paper, on a card. So the cards are still traced somewhere.
But it's because, you see, so long as there's no digitalization of records, the whole country, that's a hindrance. Because the card, someone will use it in let me name another village, Isulu in Kakamega. And so you cannot have electronic records because you want the Isulu person to know you discovered Addison's disease.
Yeah.
So that's the, oh God.
We are far. We
are near. We've just refused
to think.
We have refused to think. People are just wasting money on stupid things. We've refused to think, and we can absolutely change everything. We can. Munipe to Madara. Okay, I always ask for two things: Munipe power and a volcano. The volcano is for the idiots. They can just be up there when
Aswani would bomb everybody.
I'm telling you, and the way people annoy me. Those are the two things: Munipe power and a volcano. I don't want gunshots. Nini volcano funguka. Okay, where do people find you? Sorry. Where do people find you?
Kiambu Road as well. Kiambu Road, Nairobi Hospital, Kiambu Mall, 2nd floor.
Oh, great.
And is your consultation watu wanini katwekera wanaweza afford? I'm trying to think of a Kiambu.
2,500.
It's not too bad.
2,500. It's not too bad. Like
No,
nothing, it's not bad.
It's not bad na uko na kale ka flare kwa kusema nilienda Nairobi Hospital, right?
Hey, and you get the best.
Yeah. Asanteni sana na kwaherini. I will end this meeting. Or let me just share. March, we are doing the month of trauma. It's gonna be interesting. There are more panelists. It's very interesting because you see people just feature trauma. So we'll talk about school-induced trauma, work-induced trauma, and religious trauma. So those are the three main topics. And already one of the psychiatrists wants to do addiction, whatever. So I will send you the flyers and you can join in. Those are the panelists. The panels are a bit bigger.
Okay, thank you.
Okay, kwaherini. Asante sana.
Okay, bye. Thank you.
Okay, bye. Namsalimie kila mtu.
Sawa.
Bye.